Manoj sir, good evening, sir.
Good evening, sir.
வணக்கம் சரவணன் சார்.
வணக்கம் சார், வணக்கம் சார். சீனியர் சார், வணக்கம் சார்.
கருணாகரன் சார் இருந்தாரு.
Shubham, Dr. Shubham Jaiswal.
They are not joined.
No, they are just, he lost connection. He's coming. Shubham?
Ramanuj sir, namaskar.
Ramanuj sir kindly accepted the invitation. We were not having him for quite some time now.
Yeah. Sir, I will be now regularly. Sir, I will be joining regularly, sir.
Ajay Khanna sir, namaskar.
Khanna sir, good evening, sir. Shubham, I think you should re-log in. You have some trouble, Shubham. Professor Amit sir, good evening, sir.
Yeah, good evening, Dr. Kanagul.
Thank you, Dr. Sir. I think I apologize for the invitation error. Very sorry for that.
No issue, sir. Please. Yeah. So first case is.
Sir, we will have the epigastric mass first. Shubham Jaiswal will be presenting.
Yeah.
Shubham is having some internet issues, sir. We'll start in a minute, sir.
Okay.
Open your video, Shubham.
Yeah, Dr. Kanagul, in the meantime, can we start with the second case first? Why to waste time?
Your audio is weak, Shubham. You have to come closer to the mic.
Okay, sir. So is it audible now, sir?
Yes, but are you able to hear us?
Yes, sir, I'm able to hear.
Can you start your PowerPoint?
Yes, sir, I started, sir.
Friends, good evening, everyone. We have a very eminent faculty joining us today. We have Professor Ramanuj, Professor Amit Gupta, Professor Nitin, Professor Saravanan sir, and we have our own senior faculty, Professor Kanna sir, Mr. Rajgopal Senai sir, Jailal sir, Srinivasan sir, Karnakaran sir. We have a galaxy of faculty today. We have two important cases to be discussed for this evening. One is kindly contributed by Professor Praveen Suryavanshi from MJ Medical College, Aurangabad. And the other is by Dr. Nitin Garg, sir. It's a case of thyroid. We have got it from the PCMS and RC from Bhopal. So I think candidates are having some internet issues. Kindly bear with us. Can you share your PPT, sir? Dr. Shubham, are you with us?
Hello. Yeah, sir, can I start the presentation, sir? Sir, can I start it?
Yes, Shubham, you please start.
Yes, sir. Sir, am I audible, sir?
Yes, yes,
You are
audible.
perfectly audible, sir. Please start your presentation.
Good
Faculty,
evening to
please
one and
take
all.
over. Make it full screen, Shubham.
Yes. A very good evening to one and all. I am Shubham, final year resident in PCMS and RC Bhopal, and today I am going to present a case on thyroid under the moderation of Dr. Nitin Garg sir, Professor and HOD, Department of General Surgery, PCMS and RC, and my unit chief, Dr. Kulwan Singh sir, Professor, Associate Professor in Department of General Surgery, PCMS and RC. Shall I present, sir?
Yes.
So my patient 55 years old, resident of Devas MP, who is a homemaker by occupation, presented to us with the complaints of swelling in front of neck since 3 years and change in voice since 2 months. History of presenting illness. Patient was apparently normal 3 years back when she noticed a swelling in front of the neck, which was insidious in onset. Initially, it was around 1 into 2 centimeter, and now has gradually progressed to current size of about 3 into 4 centimeter, doubled almost. It is not associated with pain and difficulty in swallowing. She also complains of change in her voice since last 2 months. There is history of difficulty in breathing. There is no history of difficulty in breathing, dysphagia, fever, heat and cold intolerance, constipation and diarrhea, weight loss or weight gain, or palpitations. There is no history of exposure to radiation in the past. With these complaints, patient presented to us to PCMS and RC for further course of management. Past history: the patient is a newly diagnosed hypertensive on telmisartan 40 mg on 1 OD. She is not a known case of diabetes mellitus, TB, and epilepsy. The patient underwent hysterectomy with bilateral salpingo-oophorectomy in 2010, and there is no history of radiation exposure in the past. Family history: there is no history of similar complaints in the family. Menstrual history: the patient attained menarche at the age of 13 years, regular cycles of 28 days plus minus 4 days normal flow, attained surgical menopause at the age of 45 years, and her obstetric history: she is para 2 living 2, first male child, full term normal vaginal delivery. Now the first child is 31 years old, and the second male child, full term normal vaginal delivery. Now he is 28 years old. Personal history: the patient is vegetarian by diet, her appetite is good, sleep is undisturbed, bowel and bladder is normal and regular, and the patient doesn't have any addiction. So should I go on general physical examination also, sir?
Wait.
Yes, sir.
So please take over, sir.
Shubham, you go to the first slide. The examiners will ask questions and give their comments.
Yes, sir.
Sarunan sir, Ramanuj sir, Amit sir.
Yeah.
Yes, sir. Shubham.
Good evening.
Shubham.
Shubham, it was a brief history. Shubham, to begin with, which part of the country did the patient come from?
Pardon, sir?
Which part of India did the patient come from?
So the patient is from Madhya Pradesh, sir. Central
Okay.
part of India, sir.
The reason about asking this is that it is better to call to the examiner that it is an endemic area or a non-endemic area for goiter. Because diseases in an endemic area, particularly, will maybe a thyroid disease, which will have its implication. Okay, it
Yes.
is a good way to start your history. Next one is that as you have said that the lady noticed a swelling which gradually increased in size and it technically doubled the size.
Yes, sir.
Now, and recently to understand that there has been a change in the voice for last 2 months.
Yes,
Okay.
sir.
Now, with all of these in the history, what are the points in the full history that make you really think that the swelling was anything to do with the thyroid swelling? It could have been a lymph node in the neck also. Why are you at all thinking that it could have been a thyroid swelling? Because you have taken history about radiation exposure, you have taken history about constipation, diarrhea, heat intolerance. Why do you think about this lump as a thyroid?
So first of all, sir, when I saw the patient, sir, the swelling was in midline and the position, sir, and the swelling also moved
Hello, Shubham, am I audible?
I think there is some internet problem on the end of Shubham.
Hello.
Sir, give them some time, sir. I think he's been from the beginning having this issue.
Yeah, I think so. Yes.
No, sir, I will ask the other candidate to start the presentation. Harsh, you are with us? Dr. Harsh
sir.
Singh,
I'm here.
Yes, sir. I saw
Yes,
him.
sir.
Is there.
Yes, sir. I'm here.
can you start
sir.
your presentation?
I'm here,
Harsh
sir.
Singh?
Yes, sir. We can.
You please start your presentation, Harsh. Faculty, kindly accept
Okay,
my
sir.
apologies. I think the student is having some trouble.
Sir,
We
no
will
issue.
ask the next
We are
candidate
all-
from Bhopal to start his presentation. I will
Okay.
sort out the issues with Dr. Jaiswal sometime, sir. Please bear with me, sir. Very sorry for this trouble.
Okay, Dr. Harsh, you can start, please. Share
So,
your
yes, sir.
presentation.
Harsh, you please
Yes, sir.
introduce yourself, your unit chief, your head of the department, and start your presentation. Good luck to you, Harsh.
He is back, sir. Shubham is back.
Faculty, what shall we
Sir.
do?
Shubham,
I-
are you?
If Shubham is back, I think better to give him chance because he is midway.
Okay. Shubham, are you okay?
Yeah, so there is some network problem, sir. I'll just rectify it, and I'll be sharing the screen again soon, sir.
Please start this. Faculty, kindly excuse for this confusion.
Yes.
And I think we'll ask Shubham to continue the presentation, sir. Go back to the first slide, Shubham. Let the faculty take over. Thank you very much, sir.
Hello.
Yes, sir.
Yeah, Shubham, we are back now. That is good
Yes.
to be- Shubham, so the important thing, as you are trying to say or suggest, is that whenever you get a history of a patient with a neck lump, in the
Yes.
history part, if the examiner is asking you, why did you take all the histories regarding the thyroid diseases, say that, sir, the patient presented with a neck lump about in the midline of the neck.
Yes, sir.
One of the most common causes of a midline neck lump is a thyroid, and hence I took my history to rule out a thyroid disease. So this is what the examiner will like to hear. And beyond this, you have taken histories regarding constipation, diarrhea, weight loss, etc. Now, Shubham, what are the things that you wanted to say in this part of that history?
So I was looking for this for the symptoms of hypo and hyperthyroid, sir. So I took all the history of.
Apart from, so that means you are thinking about a benign disease of the thyroid, hypo and hyperfunction. Okay,
Yes.
Shubham, if it was a malignant disease of the thyroid, for any example, now what could have been other symptoms in the neck apart from the thyroid swelling?
Sir, sir, apart from neck, the patient will have compressive symptoms, and like the patient will have breathing difficulty in breathing. So the patient will have dysphagia. His and sir, history of any exposure to radiation in the past, sir.
No, wait, Shubham, please understand. So you have taken histories regarding the growth of the thyroid, say if it is a thyroid at all.
Yes, sir.
Number two, you have taken histories presuming that it was a thyroid about the function of the thyroid. The question is, whenever you are thinking about any lump, take histories regarding the benign nature of the lump, take histories regarding if it was a malignant nature of the lump. Benign nature would have been functional histories that you have taken, or compression of surrounding structure, like you have said, a difficulty in taking breath or a change in the voice may be due to a nerve compression. Whereas say it was a malignant lump, then always take history about local lymph nodes, which could have been a very important feature in a thyroid malignancy if you're thinking at all of a thyroid, because it gives you a big clue that whether it could be. Next is you are required also to know about what are the other treatment histories that the patient received regarding the lump. Can you go to the next slide on the management that was done in the hospital?
Yeah, Shubham, I just want to interfere. Go
Yes,
to the
sir.
first slide. First slide, please. Yes, see, actually, you have mentioned that she presented to you with complaints of this, but you have not mentioned when she has presented to you, right? This is a very important thing. You should not be missing on that. And go back to the slide where you have shown the negative history. Yeah. So there are a lot of things you have tried to rule out here, but nowhere you are mentioning that, as sir was asking, that if malignancy is there, so patient may also give you history of loss of appetite, or sometimes there may be good appetite despite that patient is showing weight loss, right?
Yes, sir.
But that treatment history, past treatment history, and drug history, you have not mentioned anything about any drug intake, right? Which is very important in such patients. Then family history. I go back to your family history slide.
So past history, sir, I've mentioned, sir, the patient is a newly diagnosed, sir, because the patient was
Okay. Not only that, there are certain other drugs which are more relevant when you are trying to present a case of thyroid swelling, right?
Yes, sir.
Okay. Go back to family history. Yeah. So there is just writing and telling that there is no history of similar complaints in the family is not enough, right? You have to rule out certain other disorders, like you never know whether your patient is a case of falling into a MAN 2A syndrome or MAN 2B syndrome, right? So
Yes.
in that case, it's not necessary that patients, some other family members may have similar complaints only, right? There may be some other complaints, right? Like
Yes.
patient's family member may have some pheochromocytoma or some other illness, right?
Yes.
Parathyroid disorder, something like that, right?
Yes,
So it needs to be probed in detail, and it need to be told here in detail, right? Okay.
Yes, sir.
Yeah.
Shubham,
In the first slide, you said Mrs. X. We have been repeatedly telling that, you have to give the respect to the patient. So there's nothing like the Mrs. X. Okay, we have been repeatedly telling about this for last 2 years. We have been telling this here. And then you are writing 50 years old. Okay, 50 years old is nothing. Again, you have to simply say that a lady of 50 years presented with so and so. Okay, can you go to your chief complaints? Go to the chief complaints.
Sir.
Yeah, swelling in front of neck since 3 years. Is that a okay
Yes.
word? Using the since here?
So for 3 years.
Yes. No, we have been telling for last so many years, I have been in this forum for last 2 years, more than 2 years now. And we have been telling it again and again that you have to respect the patient, nothing like Mrs. X and Mrs. Y or Mr. Y. 50 years is not the old patient. And since has to be used if it is the days and the months and the
Yes, sir.
time is there, exact time is there. Otherwise, you have to use the for.
Yes, sir.
Okay. And then in this patient, you are asking the radiation exposure for in the present history as well in the past history. Is that so relevant that you have been to ask it 2 times in the present history and in the past history?
Only past history, it will be important, sir, to know any radiation exposure in the
Yeah,
past.
but you have mentioned in the present history also the radiation here. And what is the significance of telling about full-term normal delivery for the 2 babies which has happened? What is the significance of that full-term normal delivery?
No such significance.
Good evening, sir.
Okay, so I'm just telling you that these are the small things which matters.
Yes, sir.
I'm not asking anything from just telling you all those, grammatical or verbal mistakes which are there, which are not required. Okay.
So, you have said there is a change in voice for 2 months. What do you mean by that?
Sir, actually, the patient was telling, the patient was telling that since 2 months, the patient, she's noticing this, that the high pitch of the voice, and she's not able.
He's having a high pitch voice.
Yes, sir, the shrillness of the voice is gone, sir. This is exactly what was the patient saying, sir.
Somebody having the high pitch of voice, why they get the high pitch of voice? In the thyroid, why there is a high pitch voice?
Or you want to say that she is having hoarseness of voice? What is the correct term?
Sir, hoarseness of voice is the correct term, sir, actually.
So what actually your patient is ailing from? Because high pitch voice and shrillness, loss of shrillness or more shrill voice, they are pointed towards some different etiology, right?
Vocal cords.
A little more care you must give for that. And in the next slide, we have put some short forms. What is that? PS or something? That what is that? Next slide. PCMS, RC.
So this is People's College of Medical Sciences and Research Center.
Okay. That is your college name.
Yes, sir.
That is your college name, no?
Yes, sir. Yes, sir.
No, the way you are presenting, there must be some flow, or that it must be like a history, means like a storytelling. And when you are talking about obstructive symptoms, and you must follow a certain obstructive symptoms all. You suddenly saying only one thing. Pain and swallowing are the two different extremity. Pain you are thinking because of the changes happening in the swelling. Swallowing you are taking because of the obstructive symptoms or the mechanical compression symptoms.
Yes, sir.
So okay, little more care and put in that, and you make it very short. Don't try to make it very short like this, unless it is a short case or when the examiner is asking you to present in only the glimpse of things, and you are expected to present in a systematic way continuously. And you are talking about constipation and diarrhea. Why should you talk about both constipation and diarrhea in the patient?
So
the history should say the normal bowel habits. If don't talk about negatively, saying there's no constipation, no diarrhea. But if you say it is a normal bowel habit, it is sufficient enough. Similarly, weight loss and weight gain. We are not talking about on either side to bring it. We are going to give a comprehensive picture and what is happening to the patient.
Yes, you may proceed.
Yes.
So I'm audible? I'm audible?
Yes.
Sir,
Yes.
You should talk about the swelling in the front of the neck. You have to say exactly the midline where it started, or either confined to one side, encroaching the other side like that. You have to elaborate the progress of the swelling and site of the swelling where it originated. That's also important. As faculty describe, malignant history is important in the form of any either swelling in the neck or any other swelling in the bony areas.
Yes,
But you can add and elaborate the history of present illness. And regarding the surgery, past history, you have to elaborate about surgery also. Previous history of thyroid surgery. Even if it is no history of surgery, you can say there is no history of any neck surgeries. You can say broadly, no history of neck surgeries. As faculty pointed out, you have to elaborate about the drug histories, whether the patient might have taken thyroxine or anti-thyroid drugs or goitrogenic drugs or substances. Those things also you have to say. You have to get all those histories, and you have to add like this. In spite of saying no history of drug intake, you can say like this, elaborate way. Okay, thank you. Proceed.
Where the swelling has started, in front of the neck or in the neck or in the thyroid region? Where?
Hello.
Where was the swelling? The complaint.
Pardon, sir, I'm not able to hear you, sir.
Okay, go ahead.
So Shubham, will you like to call it as a swelling is front of the neck or in anterior part of the neck? I think sir wants to ask this question. Am I right, sir?
Yes, in front of the neck is a different terminology. Even if you keep something in front, I can say it is the pen. My hand is in front of the neck. It is in the neck. In the neck, anterior part, you can say anterior triangle, or you can say better, there is a thyroid region. Because there is a boundary for a region, that is a thyroid region. Can you say the boundaries for the thyroid region? Subham, you have muted yourself. I think he has a lot of net connection problem.
Faculty, maybe we can ask him like a short case and try to finish up
Yes,
fast.
yes.
Because,
So that is better.
so that other case we can discuss little longer. Anyway, I think things are not in our control also. So kindly request so that I think he has come back again.
Sir, actually, there was some network issues, sir, so I was not able to hear the question properly, sir. So can you just repeat the question, sir, once again, sir, please?
Can you say the boundaries of thyroid region?
Sir, the thyroid region, sir,
Okay, it is better to say like what we say in groin, inguinal region, thyroid region. It is bounded on either side by the sternocleidomastoid, above by the upper border thyroid cartilage, or very specifically, if you want to say, it's oblique line of thyroid cartilage, and lower the sternal notch. So this is the region, and if you say there is a swelling in the neck in the thyroid region, that everybody understands that. Okay, you can go for examination now.
General physical examination. Here is a 55-year-old female, well oriented to time, place, and person, moderately built and nourished. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. Vitals are within normal limit. BP is 130/80 millimeter of mercury measured on right brachial artery. Pulse rate is 88 beats per minute measured on right radial artery. Normovolumic, normal rhythm. Condition of the blood vessel wall is normal. Respiratory rate is 16 cycles per minute. Temperature is 98 degrees Fahrenheit and SpO2 is 90% on room air. Local examination. Patient was examined in sitting position in a well-lit room in the presence of female attender with a proper verbal consent. Inspection. A solitary swelling of about 3 into 4 centimeter is present on the left side of the neck, which is globular in shape, extending from thyroid cartilage above to 3 centimeters above the suprasternal notch and laterally extending up to the anterior border of left sternocleidomastoid muscle. Swelling moves with deglutition. Surface appears to be smooth. Skin over the swelling appears to be normal. There are no dilated and engorged veins and no visible pulsation seen. This is the photo of the patient showing the swelling, sir, in the anterior part of the neck, sir.
So,
Yes,
Shubham,
send the
actually, there should
examination.
be a good exposure of the local region which you are trying to, verbalize, because if you see these photographs, your patient is not very well exposed, right? You can see that some other part of the neck is not completely exposed, right?
Yes, sir.
And 3 centimeter you said from the sternal notch, right? And it is going up to the thyroid cartilage. Look at again the clinical picture. It is not fitting into the description what you are giving. And again, please don't call 55-year or 50-year-old lady, right? Yes.
So,
And you
Shubham,
said
say,
it moves with deglutition, but you have not mentioned what type of movement it is, up and down?
Yes, sir, up and down movements, sir.
Shubham, examination, say, don't say local examination. Examination of the neck. Okay, local examination doesn't mean anything. Okay. Yes.
These are all the few advices we are giving for the last 2 years. That is what it is little painful to see. Candidate presenting, you are not looking into the old.
Otherwise, they will have tough time in the examination also, sir. They present like this. That means they are not presented the picture. Okay. Yes.
Shubham, now once you have described it and once you have described the inspection and palpation, Shubham, have you finished describing your palpation, or is there anything else that needs to be said?
The palpation, I'll start describing, sir. Palpation.
Okay, you have not started palpation, na?
Yes,
You've
sir.
started with the inspection.
Yes,
Okay.
sir.
Shubham, can you tell me what is the usual exposure that is done for examining patients with neck lumps, including a thyroid? What is the usual exposure? Like the image, the picture that you showed, you see examiners were not happy with the amount of exposure. What is the usual exposure that is done for thyroid swellings and neck lumps?
Yes, sir. So the patient should be exposed from the mental region till the mid nipple, sir.
So that means you need to expose both above and below the clavicles,
Yes, sir.
at least the sternum or mid-sternum. Can you tell me any importance of exposing the mid-sternal part above and below the clavicle in a patient with a thyroid disease?
Yes, sir. Yes, sir. If there is any retrosternal thyroid extension, sir, the patient will have engorgement and dilatation of vein around the around the superior part of the sternum, sir. So it is important to see those things if the patient is having any obstructive or any complication.
Okay, good one. Now, as you have finished out your inspection, what are the positions that you have examined the patient in inspection, or what are the views that you had of the patient when you saw the patient for an inspection of a neck lump, including a thyroid?
Sir, we can inspect the patient. First is the Pislow's method. We will stand in front of the patient and will ask the patient to extend his or her neck by holding his or her occiput with her hands. So the neck swelling will be more prominent, sir. The first is Pislow's method, and answer will.
Shubham, see, you are, as all the examiners are trying to make it, Shubham, always be systematic during your description. What they are asking is a very basic thing to pass the examination, Shubham. If you are going in for difficult things, they are trying to take you back to the track. If you are asked to examine a neck lump, remember that you can say the patient is exposed, as you have said. Patient is requested to sit on a chair or a stool. You should be sitting preferably at the same eye level as the neck lump. You look at the swelling with the patient's hands by the side, neck in a neutral position, your eyes at the level of the neck swelling. If you feel the patient is short-necked, obese, where you are unable to see for the lower border of the swelling particularly, you then request for the Pigelo's method. You also now stand up from the chair or the stool, whatever you are sitting into, go to the side of the neck, examine the swelling from the side, particularly the lower border. And if the patient, if you may or may not do at this position, will be hands raised above the head by the something called Pemberton's test, but that can be something we will do later on. So Shubham, if you are asked these positions of inspection, please remember that, because in palpation you will be asked again the same questions. Okay. Last and the most important thing, before you commented on, before you thought about palpation, what was your initial idea about the organ of origin of this neck lump? I am not considering it to be a thyroid. Please justify why did you say this was at all a thyroid swelling? I felt it was a lipoma. I am not at all thinking it to be a thyroid.
Sir,
did you understand the question, Shubham?
yes, sir, I understood the question, sir. I should prove this swelling is arising from the thyroid and not somewhere else.
Yeah. How? So again, the time is short. The swelling, remember, is in the thyroid region. Professor Jalal told you very specifically the boundaries of the thyroid region.
Yes, sir,
Number one. Number two, the swelling, remember, moves up. It moves down automatically. It moves up on deglutition,
yes,
which is very typical for a swelling in the midline, particularly a thyroid swelling. Okay. Number three, the shape probably is globular, which is not very characteristic of the thyroid. But if it was a butterfly shaped or one lobe, then it would had been more in favor of the thyroid swelling. So remember that these are basic things that you must tell the examiner. Examiner, please don't presume that the examiner is only going to ask you thyroid, thyroid, and thyroid. He's going to ask you how clear you are with your concepts. Then you proceed. Please, other examiners.
Yeah, Shubham, well pointed out by Dr. Ramanujam. I would love to have hear from you that swelling is also not moving with region of the tongue, right? I know that you must have done that test, but you should also speak for that, right? And second thing is that as sir is asking, can you name some swellings which are there in the midline of the neck? They are moving with the deglutition, but they may not be originating from thyroid.
Sir, it can be subhyoid bursitis, sir. It
Yes.
moves to and sir, any swelling from larynx or the prepharynx, even those swelling move with deglutition, but those are not thyroid, sir.
So it can be a laryngocele, it can be a pretracheal or prelaryngeal lymph nodes, right? Which
Yes,
can
sir.
also move with the. So again, why this question is important, because it seems that you are biased from the beginning that you are presenting a case of thyroid. So you are hell-bent to make it as a diagnosis of thyroid from the beginning, which should not be the case, right?
Yes.
So you should justify your each and every word what you are verbalizing, right?
Yes,
So
sir.
it seems that you are biased. So it should not happen in any case presentation, right?
Shubham, you said it moves with deglutition. Can you explain the
So
reason for that?
Yes, sir. Yes, sir. So the thyroid gland is enclosed in the pretracheal fascia, sir, and the pretracheal fascia.
What is pretracheal fascia?
Sir, it is enclosed with the pretracheal fascia and the
No,
posterior.
what do you mean by pretracheal fascia? What is pretracheal fascia?
So the fascia that is encircling the trachea, so that is pretracheal fascia, sir.
No, it comes from where and what is it is? What is it belongs to? Where it belongs? Is it a part of a deep cervical fascia?
Yes, sir. It is a part of the deep cervical fascia, sir.
How many layers for the deep cervical fascia? You know what is investing layer?
So investing
It has
and
three parts. You have investing layer, pretracheal fascia, then you have prevertebral fascia. So what are the structures enclosed by the pretracheal fascia?
so the pretracheal fascia encloses the thyroid gland, sir. It
What are the
encloses
structures enclosed by the investing layer? There is a rule of two. You must remember it has enclosed two muscle, two gland, two ligament. Lot of things comes. Okay. Pretracheal fascia encloses the thyroid. Then
Sir, it encloses the thyroid, sir, and posteromedially, sir, it attaches to the larynx through ligament of Berry, sir. So
larynx which part?
the posteromedially, it attaches to the larynx, sir.
No, larynx is a large part. Lot of cartilages are there in the larynx. No,
the tracheal,
trachea is not part of the larynx.
the thyroid cartilage, sir. It
It is attached to the thyroid cartilage. Where is the Berry's ligament is attached?
the Berry's
So
ligament.
it's not attached to thyroid cartilage. It is to the cricoid cartilage. And bilateral on either side, it is attached to the cricoid cartilage. So what?
So, sir, as the cricoid cartilage also moves with deglutition, sir. So this swelling will move. The thyroid will move. Any thyroid swelling will move.
Cricoid cartilage is a larynx. Deglutition is taking place in the pharynx. Why during deglutition cricoid is moving? What is the relationship of that movement with the pharynx and cricoid cartilage? You know what is inferior constrictor?
Yes, sir. Superior constrictor, middle constrictor, inferior constrictor. Yes, sir.
What are the muscles of inferior constrictor? Okay. Now this postgraduate, please go little deeper and understand and why it is deep moving. It is not just saying that it is moving. So what is the role of cricothyropharyngeus, thyropharyngeus muscle? And why it moves? It is one of the very common question, but there you are not expecting anybody to make even a small mistake. That you understand it fully. Understanding the deep cervical fascia, pretracheal fascia, its attachment, its relationship with the cricut, why it is the cricut is moving. So what? Why all the other organs are moving? Is it moving up or moving down?
So it moves up and down, so both. During deglutition, sir, it will move up and it will come back to its original position. Sir.
So that important here is only moving up.
Yes, sir.
What is the importance of that moving up? The thyroid, can you get a thyroid without moving up?
Sir, in cases, sir, when there is when we are suspecting there is capsular invasion and there is local invasion, in the cases of thyroid carcinoma, sir, the swelling will be fixed. In cases of thyroid, it will not move up with deglutition.
Any other condition where thyroid swelling is not moving with respiration, or sorry, deglutition, although it is arising from thyroid? One, you said that it may be in a case of malignancy. Any other condition you know? So when there is history of prior irradiation in the neck, right? And when there may be a prior history of some surgical intervention, right? And in Riddle's thyroiditis, right? When isthmus is so very well, fibrosed that it doesn't allow thyroid to move. Please, and lymph nodes not palpable, where?
So lymph nodes not palpable of the cervical regions.
So that you should clarify actually, right?
Yes, sir.
Where you actually look for the carotid pulsation, where you will palpate.
So carotid pulsation is the pulsation is palpated on the anterior border of the sternocleidomastoids, are in the midway, sir.
So in the midway, any bony landmark?
Thyroid cartilage, sir.
Thyroid cartilage? No, it's not thyroid cartilage. Shubham. Anyway, move ahead.
Shubham, Dr. Rajagopal Shuna here. 1 or 2 questions on this slide.
Yes, sir.
We have started palpation from behind, I suppose, number 1. First thing. Second thing is confirmation of the movement with the deglutition. Please give a glass of water. You understand, no?
Yes, sir.
It is invariably you go on telling drink, swallow, swallow, swallow. There is hardly anything to swallow, right?
Yes, sir.
Next is very important is 4/3. According to you, 4 is vertical or horizontal?
So 4 is vertical and 3 is horizontal, sir.
Why it is important? Why? What is the classical shape of thyroglossal cyst, which some discussion has been going on here? What is the shape of thyroglossal cyst?
Sir,
it's vertical oval. Vertical oval. What is the shape of subhyoid bursitis?
subhyoid bursitis, sir, shape.
It is horizontally oval. Number 1. And what is the location of subhyoid? Obviously, it is just below the hyoid. You know where is the location of your swelling. Next important point you have missed, I suppose, is mobility. You wrote swelling is mobile. Means what is that you did here?
So the swelling is, the movement is not restricted horizontally and vertically, sir.
You are talking about movement with swallowing, or movement with protrusion of the tongue, or movement on independent mobility.
Sir, independent mobility, sir.
Why it is important?
So because it is not involved the deeper structures, sir, the swelling.
What is the deeper structure here in relation to your change in the voice your patient has got? 3 years duration, change in the voice. What is that deeper structure means? Means what? What is that?
Sir, any nerve.
When it infiltrates deeper into that, the prevertebral fascia, it becomes almost like immobile, like anaplastic carcinoma or transformation to malignancy. One other important thing, according to me, is you should have mentioned what if other side lobe is palpable or not. Very important here. Rest of the gland, you have not mentioned at all. I hope I have not missed also. Is it clear?
Sir, I'm not able to hear you, sir.
What I'm trying to tell is you have written that 4/3 is palpable, correct?
Yes, sir.
What is that? Right lobe, left lobe, isthmus? What is this?
The left lobe, sir.
So where you have mentioned, number one. Second is, what about the right lobe?
The right lobe is normal, sir.
It is important to say right lobe is not palpable. Does it make a difference?
Yes, sir.
What is the difference? Suppose you have one big nodule like this and right lobe is palpable. See, there is a change in your diagnosis. So these are some observations, please correct. But movement with the deglutition, check with a glass of water. So thank you, sir. Yes.
Shubham, one more point to add.
The thyroid is palpable or not?
So normally the thyroid is not palpable.
No. In your case, you have felt a nodule or a swelling. Is it a thyroid nodule you have felt or thyroid lobe you have felt?
Sir, only the nodule as such is palpable, sir.
Have you done a Lagis method?
Yes, sir.
Palpation. How can you do a Lagis method when you are not feeling a thyroid?
Sir,
in a classical method, you are not able to palpate a thyroid. How will you do the Lagis method?
sir, in Lahey's method, sir, what we'll do, we'll sit in front of the patient, sir, and if we want to palpate the left lobe, we'll push the right lobe of the thyroid with our right hand, and we'll palpate with the left hand, and we'll palpate the lobe of the thyroid.
What is your intention of doing Lagis test, Lagis method? It is only to palpate, see whether by the classical method you are seeing whether there is a nodule on the anterior surface. By the Lagis method, you are going to see is the posterolateral surface, any nodule is there. When the thyroid itself is not able to palpable by a classical method, you will not be able to see the posterolateral surface of the thyroid. So there is no indication of a Lagis method in this case. You can only do the Kreil's method because we are already started a nodule, you have to do the Kreil's method. The reverse is true. So similarly, when you are not seeing any nodule, either by the classical or Lagis method, you should not do the Kreil's test. Kreil's is done only when there is a nodule. Lagis is done only when thyroid is palpable. Sir has talked about inspection, two methods. Any other method of inspection you will adopt? Suppose when there is exophthalmosis.
Sir,
Nepsicher method. How do you do that?
So we'll ask the patient to extend his neck, sir, and from above, sir, we'll look at the.
So that is also another way, because sir has explained you about this in sitting in front and examining, going to the lateral side and examining. So now you have to go stand behind the patient, and from above downwards, you have to look at the ciliary ridge. That is another method of inspection.
Yes, sir.
You said that the swelling is extending from the thyroid cartilage. Is that correct? Thyroid cartilage is a broad structure.
Yes, the upper border of the thyroid cartilage.
Yes, you have to say that. No?
Yes, sir.
You have to mention that it is from the upper border, whatever you want to say.
Yes, sir.
Then you are saying carotid pulsations, they are felt, where did you write? Anteriorly. What does that mean? At medial border of sternocleidomastoid anteriorly. So do you feel it at the medial border of the sternocleidomastoid? Or you have to dip there to feel for that?
So we have to dip it. We have to
dip there, not at the medial border.
Yes.
And you feel it against the C6 tubercle. Okay, not against the thyroid cartilage, but you feel it against the C6 tubercle.
Yes, sir.
Okay. What is the relation of the thyroid to the sternocleidomastoid?
So the thyroid lies so there are two heads of sternocleidomastoid, a medial head and lateral head. The thyroid will lie medially to the medial head of the sternocleidomastoid, sir.
No, there's a big thyroid is there, not like your case. A big thyroid is there. What will be the relation of that thyroid to the sternocleidomastoid?
So it will push
will it go superficially or will it go deep?
It will go deep, sir. It will push away the muscle, sir.
No, it will not push away the muscle, na?
It
It
will
will
go
go below the muscle. Okay,
below
whatever the size of the thyroid may be there, it is always deeper to the sternocleidomastoid. That you can say blindly. Even if you're not tested, you can say blindly that the thyroid swelling is deep to the sternocleidomastoid. Did you check for the trachea in this patient?
Yes, sir. The trachea was centrally placed, sir.
But you are not mentioned anywhere about the trachea here. What are the various ways to see for the trachea? To check for the trachea?
What is by inspection? What is by palpation? And any other method?
Sir, palpation, sir, with the two medial heads of the clavicle, sir, we'll feel we'll go in the midway, sir, and feel for the cartilages, C-shaped cartilages, sir, and there will be constriction. So in this way, we can feel the trachea, sir.
No, you have to dip the finger. Okay, you have to dip the finger in that gap. If you are not able to dip the finger there, then it is shifted to that side. It is not the cartilage you are feeling there, but you have to dip the finger. You can do it on inspection also. How do you see on inspection the trachea shifted?
Inspection.
Yeah, the prominent sternocleidomastoid. If you find a prominent sternocleidomastoid, it means the trachea is shifted to that side. And
Yes,
then
sir.
third way is to auscultate there. Okay, by the auscultation, you can find where is the trachea there. Okay. Right.
So Shubham, do you know what is Kocher's test?
Yes, sir.
Yeah.
So when Kocher's test, sir, when we palpate deep to the gland, so the patient will have stridor in expiration. The patient will have stridor, sir.
Why?
So because in cases of long-standing thyroid cases, sir, there is pressure symptoms over the trachea, sir. And when we push it, sir, it will.
Have you done the oral cavity examination in this case?
No, sir.
Do you think that it has got some significance?
Yes, sir.
What is the significance? What you will like to see in oral cavity examination, especially in this case?
Sir, any lesions in the mucosa, sir?
Which lesion?
Sir, in the gingiva, sir.
Will you like to rule out something at the base of the tongue? Okay, what is the commonest site of ectopic thyroid?
Base of the tongue, sir.
Move ahead. Carry on. Actually, there are a lot of inconsistencies in your presentation, right? Lot of them, right? In palpation, you have actually just run through certain things, which actually was not supposed to be the case. But I think there's a paucity of time. So, and there's another case. So, please, next slide. Yes. Have you done percussion?
Yes, sir, I've done percussion, sir.
But it is not mentioned here. Where you have done the percussion?
Sir, on the mediastinum, the lower border of the thyroid, sir, in the mediastinum, sir. Sir, if there is any retrosternal extension of the thyroid, sir, that normal resonance sound will turn dull, sir, because of the extension.
Okay. So you have done all the examination. What is your diagnosis now?
Sir, diagnosis, sir, mostly this is a solitary thyroid nodule, probably benign etiology. Mostly a colloid nodule, dominant nodules.
Why you are, yes.
Sir, just one point to make, Shubham, before we come to the diagnosis. Shubham, have you seen for any clinical signs of hypo or hyperthyroidism in this patient?
Yes, sir. I've seen, sir. I've asked for the signs, sir.
Yeah, I'm not asking symptoms. You told me the symptoms in the history. Signs means you look for signs of more function, like eye signs, hand tremors, etc. For hyperthyroidism, and for hypothyroidism, again, you see for critibial myxedema. You see for not critibial myxedema, you look for petechinas, you look for coarse facial features, etc. So, have you seen for any thyroid functions? Because they don't this is the slide.
Pardon, sir?
So, Shubham, you have only mentioned inspection, palpation, and then percussion and auscultation. But remember that if you are trying to mention a thyroid, always remember examiners will always be required. It is a hyper-functioning thyroid. Please remember that. And if it is hyper-functioning thyroid, please remember that we have to know whether there is an associated malignancy or not. As time is very short, please proceed with the other examiner's question, but kindly mention this in your history in the next time. Okay.
Yes.
Thank you. Please.
Shubham, your diagnosis is solitary nodular goiter. Can you define what is meant by solitary nodular goiter and other goiters, like what is the dominant of multinodular goiter, dominant nodule of multinodular goiter and solitary nodular goiter? Definition. Can you make definition?
You are muted, Shubham. Sir, you may be having issues with the net. Yes. Shubham, we are not able to get you. Not, we will go to the next.
Dr. Kanagavel, can we go for the next case then?
Okay, Kanagavel sir, Harsh, you are ready? Kanagavel sir, let's come back.
Harshing is to join. Harshing has already joined, sir.
I think we will go back. Go to him, sir.
Harsh?
Yes, sir, I'm here.
Yeah. Thank you, Dr. Jaiswal. Professor Nitin is here. Yes, sir. Sir, would you like to give your comments, sir? Actually, this boy was little scared. Nitin sir was telling. I said, anyway, don't worry, sir. We will help him out. So, Nitin sir, we'd like to listen to you and then we move to the next case.
Yeah, so I think he has a lot to learn and he has probably learned a lot from today's class. And there was some network issue going on. Actually, weather is very bad today in our city. Lot of raining, thunderstorm going on. I don't know. Even I am facing the same problem.
Okay, sir.
So I thank to all the faculties for the guidance, for the questions and grilling of the candidate. Probably it will improve them. Thanks to all.
Nitin sir, I request you to stay back for the next discussion also.
Sir, I have to leave actually. I have got my case lined up today. So that I somehow I joined.
Thank you very much.
Okay, thank you. Thank you, sir.
Thank you. Harsh, you please start your presentation.
Okay, sir. Sir, am I audible?
You are audible, but we are unable to see your PPT.
Good evening, everyone. My name is... Sir, I shared the PPT right now.
Yes, please go ahead.
Good evening, everyone. My name is Dr. Harsh Singh. I am from MGM Medical College, Aurangabad. I am currently working under Dr. Musande sir as HOD and Dr. Suryavanshi sir as my guide. So I will start with the case now.
Go ahead.
So my patient, age 54 years, married Hindu male, resident of Aurangabad, shopkeeper by occupation, came to OPD with the chief complaints of pain in abdomen since 2 months, distension in upper abdomen since 1.5 months, and loss of appetite since 1 month. Patient was apparently well 3 months back when he developed pain over his upper abdomen, sudden onset, colicky, and radiating to the back. Pain was continuous in nature with colicky episodes in the middle and the episode got relieved on medication. This pain was associated with episodes of vomiting, which were 3 to 4 episodes per day, non-bilious, non-blood state. Patient took treatment at a local clinic and was given IV fluids and unknown IV medication on OPD basis for 3 days. Patient has no history of fever, jaundice, or altered sensorium during that episode. 1 week following that episode, patient developed a dull, aching, continuous pain over the upper abdomen, radiating to the back, which was partially relieved on bending forward. This pain has persisted since then and has gradually increased in intensity. The patient has had 3 to 4 similar episodes of sudden onset pain with vomiting in the last 1 year without any history of proper admission and has received treatment at local clinics. Patient complains of abdominal distension, which was initially mild, which progressed to a swelling, presently localized to the upper mid-abdomen over the last 1.5 months. Progression of the size of swelling was associated with progressive loss of appetite, according to the patient. Currently, the main complaint of the patient is loss of appetite and early satiety since the last 1 month. Patient has no history of fever, no history of significant weight loss, no history of hematemesis, melena, hematochezia, no history of yellowish discoloration of eyes, skin, or high-colored urine, no history of heartburn or regurgitation, no history of trauma to abdomen. Patient has no history of cough or dyspnea, no history of sudden increase or decrease in size of the swelling. On inquiring about the family history, patient has no similar complaints in the family. The patient has no history of diabetes, hypertension, or tuberculosis. Patient has no history of any surgeries, any interventions done, or any specific medication taken. Coming to the personal history, the patient is a chronic alcoholic since 10 years with a daily consumption of at least 50 to 100 ml of any type of alcohol. Patient prefers local brand. There is no history of any smoking or drug abuse. Patient has altered sleep since the development of this dull aching pain. Patient's appetite has reduced over the last 1 month, and the bowel bladder habits of the patients are normal.
First, you said about the pain in the abdomen.
Yes, sir.
Epigastric region, right?
Yes, sir.
And also said colicky type of pain.
Yes, sir.
What do you mean by colicky type of pain? Can you describe the colicky type of pain, nature of pain?
So sudden onset pain, severe pain, which is intermittent. Sir.
It persists for only few seconds.
Yes, sir. It is intermittent. It persists for very few seconds.
Suppose the same thing happens to the epigastric region.
Yes, sir.
What you can correlate? Which organ you can correlate?
So basically, colicky pain happens when there is luminal obstruction, and the obstruction is relieved. So in these cases, sir,
commonly, what are the things used involved?
Sir, it can be due to a common bile duct stone.
Yeah, we got named colicky. Okay.
Yes, sir.
What are the named colicky pains? You know.
So biliary colic, which is in CBD. Ureteric colic, sir.
Ureteric colic.
Yes, sir. Colicky pain of the intestine, sir.
So intestine also. Okay.
Yes,
so
sir.
patient may say, but you have to arrive which type of pain? Is there dull aching pain?
Yes,
like
sir.
that. If it is colicky, can you consider this as a colicky pain?
Sir, actually, what patient said was patient developed a pain which was intermittent, lasting for few seconds only.
Okay.
But he had a baseline pain also. So basically, he had a continuous pain with colicky episodes in the middle.
Maybe started with the colicky pain, followed by dull aching and constant pain. Okay.
Yes.
What do you mean by radiation? Is it radiation type of pain? Isn't it?
Yes, sir.
Radiation to back. What is
Yes, sir.
referred pain? What is radiation pain?
So referred pain and radiation pain are so when the primary origin of the pain. So basically, in referred pain, the pain travels along the path of the reference from the organ of origin till. Sorry. So in radiating pain, the
Radiating, yes.
pain travels around the path of the neural pathway. So from the organ of origin till the place where the pain is radiating, the pain is there. The
Goes through
Continuity
the
will be
neural
there, yes.
pathway. As what you said, radiation goes through the neural pathway.
Yes, sir.
No, it's not the neural
Not so.
pathway.
No, sir. Not the radiation pain does not go through the neural pathway. It is due to have the two sides having the sharing the same uh, uh, spinal level of nerve
So only the
innervation. Sir.
spinal nerve can produce a referred pain, not the cranial nerves. Huh?
So they can, sir.
Then what is your definition for that? Referred pain means what? What do you mean by referred pain?
Sir, referred pain means when there is it's a pain which originates as at an organ, but is also present at another site, which has the same origin of nerve supply.
Yeah, here radiation and referred also two sides pain appreciated, right?
Yes, sir.
What is the difference? In referred pain, there will be a discontinuity. Okay.
Yes, discontinuity, sir. And
Yeah, in
radiating pain,
it will be
the whole pathway will
continuous.
be
Continuous.
paining.
Okay. You said
Yes.
there is no change in size of the swelling. Can you say some swellings in the abdomen that changes in size?
Yeah, Harsh, actually, I have an objection to that. Should you call it abdominal swelling or abdominal lump?
Sir, generally, what we call lump is an palpatory finding.
Oh, you want to say that, but it is visible to you, probably is swelling, right? And on palpation, you will say it is a lump. Is
Yes,
it
sir.
so?
So that's what I have done.
No, that's not the case actually.
Okay.
Right?
Sir. Okay.
Go ahead.
Yeah, what are the swellings that change in size? Or disappearing, again reappearing?
Sir, intra-abdominal.
Examples.
Sir, duplication cyst. Sir, and sir, even pseudocysts can regress.
Yeah,
in
pseudocysts. Yes.
And sir,
what is Dytel's crisis?
Dytel's crisis, sir. And when there is obstruction,
okay.
hydronephrosis, when
yeah.
relieved, the patient feels when the obstruction is relieved suddenly.
Yeah, in the neck, can you give an example? The neck swelling changes in size. Neck.
Sir, plunging ranula.
Okay, plunging ranula and cystic
larynx.
Okay.
Yes,
you go ahead. Go ahead. The abdominal examination. Okay, history.
Yes. Sir,
why you are asked history of trauma to the abdomen? But what is the relevance of it?
Sir, in case of trauma and post-trauma development of swelling, we can suspect a hematoma which has formed due to the trauma, or we can expect a even pancreatic injury can cause pancreatitis followed by pseudocyst in pancreatic trauma. In liver trauma, in actually all solid organs, we can suspect a hematoma formation.
So hematoma in viscera or hematoma in peritoneal cavity or abdomen?
Sir, any hematoma that encapsulated hematoma will present as a swelling only, sir.
Okay.
Harsh, you are having a patient having a lump in the epigastric region, and you
Yes,
are repeatedly talking at one term. There's a loss of appetite. Anything
Yes,
we are interested more on the appetite.
So because of the lump
more
in,
significant point in what type of appetite or what features we ask as important when you have an epigastric lump.
So basically any epigastric lump can cause pressure symptoms which will cause gastric outlet obstruction or early satiety because of
No, it is-
compression of the stomach.
Early satiety is more important than loss of appetite. You are now
Yes, sir.
talking about, and there is no reason to say there is a progressive loss of appetite. Why there should be progressive loss of appetite here?
Sir, actually, that's what the patient said. That's why I mentioned in the history.
Present history, it is in your language. The scientific language you are putting.
Okay.
So if you had to put the one word of early satiety, that
Yes,
would have been much more easier. In two important conditions, in epigastric lump, you will get early satiety. What are the two differential diagnoses? Suppose the patient has an early satiety. One is carcinoma stomach.
Carcinoma stomach or any
Second
external
one is an
compression.
epigastric, pseudo pancreatic cyst. So if there is
Yes,
something on external compression, the bowel distance is not passed. So the complaint must be early satiety. Whatever they little eat, they feel full. So that is different from appetite. Appetite is entirely different. They may have a good appetite, not the loss of appetite.
But patient will have early satiety.
Have you asked for any altered bowel habits?
Sir, I did ask. Patient has no altered bowel habits.
Have you mentioned it?
Yes, sir. Sir, I have mentioned it in the personal history.
Okay. What about any steatorrhea history will ask for? Suppose if you consider the swelling to be pancreas.
Yes, sir.
Steatorrhea history. How will you elicit the history for steatorrhea?
Sir, I'll have to ask the patient if the stools are sticky and do they stick to the basin, and are they frothy and silver color?
Bulky, sticky, and foul smelling. Okay.
Yes, sir. Foul smelling.
Yeah, that also you can ask. Okay.
Yes.
So you are having epigastric lump. Why do you are asking for a yellowish discoloration? Is it DD for liver or anything else you are thinking?
Sir, yellowish discoloration jaundice can be there in case of any obstruction, sir. Any lump in epigastrium or RHC can cause external compression on the CBD. So we have to rule out that possibility. Sequelae, as a sequelae also, and as an etiology also, we have to ask.
So what kind of jaundice they get?
Sir, obstructive jaundice.
Okay.
So that's it for the history, sir.
Okay, doctor, before we proceed to the examination, in your summary of the history, can you think about what could be the organs in your mind before you touch the abdomen for palpation?
Yes, sir. Sir, since on the history, sir, we have progressive loss, progressive epigastric lump, which is increasing in size, and there is early satiety and loss of appetite. So that means the lump is compressing or originating from the stomach, which might be from the stomach, from the liver, from the biliary tree, or from the retroperitoneum, that is either pancreas or any retroperitoneal mass itself.
Okay, so that means you are thinking about organs that are located usually in the peritoneal cavity, like you're thinking about the stomach, left lobe of the liver, and in your DD, you are trying to keep the retroperitoneal pancreas as your DD. So your examination will like to focus on these points, isn't it, doctor?
Yes, sir. Yes, sir.
So now please proceed with the examination.
In the history, you have said altered sleep pattern.
Yes, sir.
What do you mean by that?
Sir, because of the pain, only because of the pain, the patient could not sleep at night properly.
What is in the altered sleep pattern? Altered sleep pattern denotes the patient, normally we sleep in the night. Somebody sleeps in the day and wakes up in the night. It's called altered sleep pattern. That is a picture of?
Sir, the metabolic disease like thyroid diseases or
thyroid. No. Thyroid, even daytime they can't sleep. It's a typical problem, liver cell failure, liver
cell failure. Yes, sir. Yes, sir. Liver cell failure.
So by putting that altered sleep pattern, now you are bringing in liver also inside. You are thinking a possibility. So certain words which you are putting is not exactly what the patient had meant.
Yes.
The patient might have said that he is not able to sleep. So you must say the sleep is disturbed or sleep pattern is changed.
Okay, sir. Yes, sir.
First thing, one more point to add. The organs involved in the epigastrium, you can add spleen also.
Yes, sir. You can add.
Aorta, okay.
Yes,
Then
sir.
mesentery, anything arising from the mesentery and peritoneum, that also we can
Yes, sir.
consider for differential
Yes, sir.
diagnosis. Okay,
Yes, sir.
okay, proceed.
So Harsh, in this case, when you can actually witness a sudden increase in the size of the lump.
Yes, sir. Sir, in case of lesions like hydrated cyst or pancreatic pseudocyst, if there is hemorrhage, intracystic hemorrhage, there will be sudden increase in the size of the lump.
Okay.
And gradual fast increase will be seen in malignancy.
Okay. So as you were asked to summarize your history, so based on the history alone, what is your diagnosis? Can you zoom on to some diagnosis just based on the history alone?
Sir, since the patient has a history of chronic alcoholism,
Yes.
and has been taking a good amount of alcohol every day for the last 10 years, and on history, patient has episodes of pain with vomiting, multiple episodes in the past, which can be made out to be acute pancreatitis. So based on this, we can think of a lesion arising from the pancreas.
So you want to say that this patient was having recurrent episodes of acute pancreatitis,
So
or
that,
he was an established case of chronic pancreatitis with acute exacerbations. What do you want to say?
sir, he had multiple cases of acute pancreatitis because he has no symptoms that indicate towards chronic
Yes,
pancreatitis
there
like
is lot of difference between saying acute pancreatitis or
and acute.
chronic pancreatitis with acute exacerbation. That is what
Yes,
sir
sir.
is asking. What do you mean to say it is an acute pancreatitis or a chronic pancreatitis with acute exacerbation?
So chronic pancreatitis will have either steatorrhea, chronic pain, or diabetes mellitus, which is not there on the history. So patient has had episodes of pain with normal
What
intermediate
is your
periods.
symptom or duration between the pain and the swelling?
Sir, multiple episodes were there for the past 1 month, but after the last episode, only one week after the episode of pain, the
So
patient developed
what do you call that swelling
distension.
is? What do you suspect this swelling could be then? Or the lump could
Sir,
be?
it can be an acute pseudocyst. If
So
we
what is the
think it's
definition
a
of pseudocyst?
pancreatitis.
Acute pseudocyst?
Sir, acute pseudocyst is a cyst that is formed around the pancreatic and peripancreatic collection, which is whose wall is only composed of the granulation
You don't talk
tissue
about
and
the
less of fibrosis.
duration. What is the acute fluid collection and acute pseudopancreatitis? What is the difference?
Sir, less than 4 weeks. Sir.
Okay, here your week is only 1 week.
Yes, sir.
So can you call this as a pseudopancreatitis?
Sir, in this case, we cannot. Sir, because sir, we can actually, because it might have been developing since before, sir, before the last episode.
No, you can't go on saying that. So one thing you are saying that is acute pancreatitis. It cannot last for a longer time for an acute pancreatitis. Once the patient is having, or then he will go into the complications. So acute pancreatitis, within a 1 week, you are getting a collection. So
Yes,
it
sir.
is only a fluid collection.
Acute
Pancreatic fluid collection.
Yes, sir.
You will not be putting the name only after 4 weeks. So you
Yes,
get what are the types of fluid collection you get? One is acute peripancreatic fluid collection.
sir.
Another is the pancreatic cyst.
Yes, sir. Then there is
Then
acute necrotizing collection, sir. And then there is Waldorf necrosis.
So within this 4 only you have to choose. So
Yes,
here
sir.
within a 1 week, if you are saying that is a collection is there, such a lump is there, it is the terminology as such you cannot put in as a pseudopancreatic cyst.
Sir, actually the cyst developed after, the swelling developed after 1 week, but right now the patient has presented after 1.5 months. The last episode, patient had pain. Then 1 week after the distension started, and now patient has presented after 1.5 months of that episode.
So now he is presenting to you after 1.5 months.
Yes, sir.
Okay, go ahead.
Yes. So patient was conscious, oriented to time, place, and person. Patient is cooperative. Patient was examined in a well-lit room after taking due consent. BMI of the patient was 22.2 kgs per meter square. Pulse was 74 per minute, regular rhythm. BP was 110 by 80 mmHg in right upper limb in sitting position. Respiratory rate was 20 per minute. The patient was afebrile. There is no icterus, pleural, cyanosis, clubbing, lymphedema, or limb edema.
Harsha,
No.
I mean, we don't normally, as we don't interfere here, but I want to know, you said 22.2 kilogram per meter square. What do you mean by that?
Yes, sir, that is the BMI, sir.
So you say the BMI per meter square. So what is the normal meter square? What is your surface area meter square?
Sir, it's not surface area, sir. It's exactly.
You said the word, it is per meter square.
Sir, well, the unit is meter square because we divided
no
by
unit.
square of
Only,
height.
only the number is a unit.
Index
It's a
only.
formula. Kg by meter square is a formula.
Yes, sir.
So it's better not to put that. Though the SWOTs, one book is using that terminology, don't use the word as a kg per meter square. It is for a whole individual. You are going to say that.
Okay, sir. So there is no icterus, cyanosis, clubbing, lymphedema, or any edema seen. No fullness in the left supraclavicular fossa is seen. Coming to abdominal examination, the examination was done in supine position. Abdomen is of normal shape with visible swelling in the epigastrium. Umbilicus is central and inverted.
I will stop you here. Before you start describing this, again, you have to tell the examiners that in this position, your patient was exposed from this point to this point, right?
Sorry, sir.
You need to be very categorical on that.
Yes, sir. Yes. Sorry, sir. Patient was examined in supine position after exposing the patient from above nipples till mid-thigh. The abdomen is of normal shape with visible swelling in the epigastrium. Umbilicus is central and inverted. A globular swelling is seen centrally in the epigastric region, extending from just below the xiphoid till 5 centimeters above the umbilicus and extending 4 centimeters on either side of the midline. The surface of the swelling is regular and has ill-defined margins. The swelling does not move with respiration. Swelling disappears on head rising test. The other regions of the abdomen move normally with respiration. There are no scars or dilated veins seen over the abdomen. The hernial sites appear normal, the external genitalia appears normal, and the spine examination was normal on inspection. So this is the swelling that was visible.
On straight leg raising test?
So on straight leg raising test, so the swelling was less. Sir, actually on head raising test, the swelling was more disappearing than the leg raising test.
No, but you have not mentioned about the straight leg raising test here. That's what I am asking. Was there any problem in the knee joints of the patient?
No, sir.
So why you have not done that?
Sir, I did the head raising test.
What, any specific reason for head raising test? Why not straight leg raising test here? Or in this location of the lump, you are more comfortable with this?
So since the lump is situated in the epigastric region, the head raising test will give more accurate results.
You want to say midline?
Okay.
So what is your interpretation?
So that means the lump is intra-abdominal.
Intra-abdominal?
Yes, sir.
Okay.
Not in the wall of the abdomen.
You said the globular swelling.
Objective of doing head raising or leg raising test?
Sir, the head raising or leg raising test is to see if the visible swelling or lump is intra-abdominal or originating from the wall of abdomen.
Which muscles you want to contract?
Yes, sir.
Which muscle you are interested to contract?
So sir, when we do the head raising test, the rectus abdominis is contracted, sir.
So, when you are doing leg raising?
So with rectus abdominis, the obliques also contract.
Preferably when the swelling is in the lower abdomen, because
Yes,
where
sir.
you want that muscles to contract, the head raising test will not help you in the lower abdominal swelling. So there it's a
Yes,
head
sir.
raising, leg raising test is important. But here in the upper
Yes, sir.
abdomen, it is head raising test is good enough for you to give a value that whether it's sufficient to the contraction and intra-abdominal, you can look it out.
Yes, sir.
Here, rather than saying globular swelling,
Yes, sir.
it is not so. You can say fullness in the epigastric. You are in the inspection stage, you know.
Yes, sir.
So we can say fullness in the epigastric region. That's all. What we are seeing is we cannot
Just a
make
fullness,
out
sir.
globular swelling
Yes, sir.
by inspection.
Only when you are seeing all the three
Globular
dimensions.
means all
Yes,
the
sir.
borders should be. That is the meaning, real meaning of globular swelling, right?
Yes, sir. Proper swelling.
That's one thing. And you are not mentioned about peristaltic movement. Any peristalsis in the abdomen? Is it important or not?
Yes, sir. Yes, sir. Important, sir.
Yeah, that you have to mention. Yeah.
Yes, sir.
Suppose if we consider carcinoma of stomach,
Yes, sir.
that is important, right?
Yes, sir.
Yes.
Visible peristalsis. Sir, on palpation, the abdomen is soft, non-tender. Inspectory findings are confirmed on palpation. An 8 into 8 centimeter lump is felt in the epigastric region, smooth surface, ill-defined margins, firm consistency, and non-mobile. There are transmitted pulsations felt over the lump. Spleen, liver, and kidney are not palpable. Hernial and external genitalia are normal. Hernial sites and external genitalia sites are normal.
Yeah, you have to
Sir.
talk about individual mobility,
Yes, sir.
right?
Yes, sir.
But hold the swelling.
In both
move.
axes, the
Individual
mobility.
mobility.
Yes, sir.
Look for individual mobility.
Yes, sir. Hello.
Yes, Harsh, move it.
Okay, sir. So percussion and auscultation on there was dull note heard over the lump. The rest of the abdomen was tympanic. The liver span that was calculated was to be 11 centimeters. On auscultation, normal peristaltic sounds were heard all over the abdomen. So
You are
PR,
percussion only over the swelling, over the lump, you are learned the percussion.
sir,
Any
over
other
the lump,
percussion?
dull note over the lump and tympanic note all over the abdomen.
What is prop space?
Yes, sir.
Prop space.
Sir, sir, I cannot remember. Sorry, sir.
So is it close to the liver or it is away from the liver?
So close to the liver only, sir. The triangular space.
No, you are not. This dullness is continuous with the liver dullness?
No, sir.
No.
On
you
palpation also and on percussion also, there was no
it's
continuity.
better you put that when you are talking about the dull sound, and you
Yes,
must
sir.
say whether your neighboring prop space is dull
Yes,
or
sir.
it is resonant, and
Yes.
what is whether it's continuing, and have you checked for any fluid?
Sir, on there was no.
No, you are not mentioned neither on inspection, and now also you are not mentioning there is any fluid. We are talking about pancreatitis. Pancreatitis is known to produce a fluid collection.
Yes, sir.
But you have not done any test to say that whether there is any fluid collection.
Yes, sir. But sir, if we have done the test and we have not found the result to be positive, then also we have to mention it as negative. So, like there was no thrill on.
You may not get a thrill. Thrill you get in a very extensive thing.
Extensive. Yes, sir.
Whether you are looking for a shifting dullness or any other way, you looking for the fluid,
Yes, sir.
minimum fluid collections.
Yes, sir.
Also, Harsh, upper border is important, right? Insinuation
Yes,
of
sir.
finger under costal margin that we have to find out.
Under the constant margin.
Yes, that we have to find out. And upper border, whether it is felt or not, that also you have to
extending
be
into
specific.
the thorax. Yes, sir.
The swelling is not moving with respiration, no?
Not moving with respiration.
So it has an intrinsic mobility.
Intrinsic mobility is also not this. Non-mobile and not moving with respiration.
Totally it's not mobile. So fixed structure.
Yes, sir. It is not moving.
If it is so fixed, it will be so tense.
Sir, it was tense. Sir, on palpation, consistency was firm, sir.
Okay, sir.
Harsh, actually, you have written like PR examination is normal and other systemic examination is normal, right?
Sir, I was going to explain, sir. I've written it, but I was going to, while
Yeah,
presenting.
see, actually, if all the faculties concur, I will like to advise you that use word unremarkable, not normal, right?
Okay, sir. Okay, sir.
I think rest of the faculty members also agree to it.
That is
Yes.
true, sir. Plus, you don't commit anything like that. Completely normal, no problem, like that.
Okay, sir.
You are said that you are not able to find out anything. So it is unremarkable.
Unremarkable. Okay, sir.
So what you auscultated? You said there is a transmitted impulse was there. Transmitted pulsation was seen.
Which
was you felt.
Sir, transmitted pulsations were felt over the lump. Sir.
Okay. So auscultation, you have not felt anything.
Sir, on auscultation, there was transmitted pulsation, but not any bruit or bruit was not there.
Bruit. Where do you look for bruit?
In case of a swelling, sir, if there is, in case of aneurysms where there is turbulent flow of blood, bruit would be.
Where?
On palpation, first thrill should be palpable.
Where you look for bruit? Proximal or distal?
Proximal, sir.
So you have to look for the thoracic aorta, you look for the bruit.
Sir, either proximal or over the swelling, sir, if you are suspecting an aneurysm.
Over the swelling is not bruit.
Okay, sir.
My sister. Sample.
Okay, go ahead. What is your diagnosis?
So, summarizing my case, a 54-year-old male chronic alcoholic came with chief complaints of dull, aching epigastric pain, which was relieved on bending forward, progressive swelling over the upper abdomen, and associated progressive loss of appetite, with a history of multiple episodes of sudden onset colicky epigastric pain with vomiting. On examination, a firm 8 by 8 centimeter non-mobile intra-abdominal lump in epigastrium with ill-defined margins, does not move with respiration and with transmitted pulsations present. There was no organomegaly. Sir, depend on the history and examination, I would like to give my provisional diagnosis as pseudocyst of pancreas.
So the pain is due to?
Hello? Yes,
the pain your patient, colicky pain, you said the patient has a colicky pain. That is
right now. Right now, the patient has only dull aching pain at the upper abdomen. He has history of multiple episodes of colicky pain. Right now, the only complaint is his first complaint is early satiety or loss of appetite.
If there is pain in pancreatitis, what is the reasons for pain in pancreatitis?
Sir, firstly, the pain is due to outflow obstruction of the pancreatic ducts. Because of the intraluminal hypertension, there is pain. And
you are talking about acute pancreatitis, I suppose, or you talking
yes,
about
are you
talking about chronic pancreatitis? So you are talking about pancreatic ductal hypertension.
Sir, in all acute in chronic pancreatitis, pain might be due to fibrosis and involvement of celiac axis.
Celiac axis.
There is a celiac plexus behind the pancreas. So
pain is basically because of the pancreatic ductal hypertension and involvement of retroperitoneal nerves, right?
No, sir.
In inflammatory process. So that is in chronic pancreatitis. But here you never mentioned anything about chronic pancreatitis. No? You were all the time saying that it was acute pancreatitis.
Yes, sir.
Just one, sir. What is the duration of this patient symptoms? Total.
Sir, totally 1 year, sir. The episode started since 1 year, and the pain and swelling has started since 1.5 months.
So multiple episodes like this. Pseudocyst is more common in acute or chronic pancreatitis?
Chronic pancreatitis.
And what is the cause of the pain has been already mentioned.
Sir,
Strictures.
in case of chronic pancreatitis, because of ductal obstruction due to strictures or calcification.
You said outflow obstruction, strictures, multiple strictures, and
Yes,
what is
sir.
that? Ultimately, stenosis, sorry, strictures, calculi formation,
Yes.
all that, that is what has been. See, alcohol doesn't mean it's acute pancreatitis. Please remember that.
Yes.
The reports are going on since many years. So you probably also keep it in mind that possibility here. You have to keep it in mind.
Now, that is one of the very common question. May not be even a clinical side. In the theory examination, the question asks the pain pathways of the pancreatitis.
Yes.
You read Swartz, it gives a very beautiful descriptions of many etiologies of the splanchnic nerves or the retroperitoneal nerves. All that is important to understand that.
Okay, sir.
Ductal hypertension is the word which you can use. It is good. You said outflow obstruction. Ductal. That is what forms the basis of what surgery quickly?
Sir,
ductal hypertension. Yes.
So for chronic pancreatitis, divergent surgery is like pancreatic jejunostomy.
So LPJ, whatever it is. That comes.
Yes.
Okay.
It's not diversion, it's a drainage procedure.
Drainage procedure. Sorry, drainage procedure. Yes.
Is your diagnosis correct when you is complete? As a postgraduate student, you will say you will stop with the pseudopancreatic cyst.
Pseudocyst of pancreas compressing over the with pressure symptoms compressing over the stomach, causing early satiety.
No, that's all. You don't ask the summary. So what are the what are the basic classifications on the pseudopancreatic cyst?
Classification, sir. It can be an acute or a chronic cyst, sir. Acute cyst.
What you are fearing with the pseudopancreatic cyst, and when the treatment modality change, whether it is a communicating or non-communicating?
Yes, sir. Communicating or non-communicating. Sir, it is a DIDGO classification.
What are the factors included in the DIGIDO classification?
So the communication with the pancreatic duct, the anatomy of the pancreatic duct. These
stricture
are the two stricture formations.
So it is just a pseudocyst of pancreas. So you must know whether there is any associated infection is there, associated communication is there.
Yes, sir.
How you are going to proceed now?
Sir, once the patient is admitted, and we have seen that at present the patient is not having a acute episode of pancreatitis. So we'll like to evaluate the patient. Firstly, we'll do, sir, the blood investigation. In that, we'll do.
Why do you want to do blood investigation first?
Sir, to confirm that the patient is not in an acute episode, sir.
Not even?
If the patient is not in an acute pancreatitis episode or in sepsis, in case of an infected case, sir.
Then it leads to some other discussion, but please understand, always we want the confirmation of your diagnosis as the first step. All your investigation, you are interested to do the confirmation.
Okay, sir. Sir, in this case, on blood investigations, we'll do complete blood count, LFTs.
No. Confirmation. SAR has given clue, no? SAR
Okay,
has
confirmation.
Given clue. Confirmation, SAR said. So always confirmation anatomically by imaging.
Imaging, sir.
Then only you can go to the functional test. Okay. It may be liver or some other organs, right?
Yes.
Stomach. First you confirm anatomical origin, then go for the other investigations. Okay. So imaging, which imaging will you choose first?
Sir, first we'll do a ultrasonography of abdomen, sir.
Yes, simple basic, yes.
Yes.
What are things you can see in the ultrasonography?
Ultrasonography, sir, we can see the exact, the location of the lump, the nature of the lump, if it is solid or cystic. Sir, sometimes we can also see involvement of surrounding structures. If we shift to Doppler, we can see the condition of the blood vessels surrounding the lump. We can see the condition of the liver in this case because we have to see for acute changes due to chronic alcoholism. We can look for ascites in this case because the patient is chronic alcoholic if there is liver disease. We can see, we can confirm non-involvement of the biliary tree by seeing the diameter of the CBD.
Okay, you are confirmed that it is a pseudocyst. What additional things you will look for? What additional things in ultrasound you look for?
We'll look for the nature of the cyst, which if it is the echogenicity of the cyst content, the condition of the pancreas at present, the pancreatic duct can be seen sometimes if it is dilated.
No. Pseudocyst, you cannot see the duct and all that. Okay. First of all, location of the cyst, where it is actually present for your planning management, right? Whether it's the head region, body region, or some other region, tail region, or in the lesser sac, like that, you have to see. Then, whether it is pseudocyst or walled-off necrosis or peripancreatic fluid collection, or pancreatic necrosis. Necrosis and all that you have to see.
Yes, sir.
Then, as we said, any debris, as a clear fluid or any debris for your planning management. There's open surgery or endoscopic surgery like that. Any associated infection, any turbidity of the fluid, all these things. Then wall thickness.
Wall
thickness is important. Why?
So to plan the
yes,
sir, to plan the
So Harsh, on ultrasonography, you will also like to see whether there are gallstones or biliary.
Sir, I was coming to that. Sir. Yes,
right?
Sir.
Although your patient is giving history of alcoholism, but even then, you should remember that the commonest cause of acute pancreatitis is gallstone-induced.
Gallstone-induced pancreatitis.
So will you do Doppler also?
Yes, sir. We can do Doppler also, sir. We have to look for the complications of pancreatitis like portal vein or splenic vein thrombosis.
So what will be the feature?
So there will be the flow will be, sir. Sir, I don't remember the term exactly.
Pancreatic thrombosis that lead to aneurysms, which can lead to gastric varices.
Yes, sir.
So when you have a gastric varices, and when you are having the varices around this also, the surgery will be problematic. And there is you will have a lot of pre-operative steps has to be taken. So Doppler is also important.
Yes, sir.
What is the rule of it is not intrapapillary neoplasm of the pancreas, IPMI.
Sir, yes, sir. It can be, sir. For that, we'll have to further diagnose using CECT contrast enhanced CT scan.
Ultrasound may not be giving you more value, but you have to do the CT also to rule out IPMI.
Yes, sir.
Suppose portal vein thrombosis is there. What additional things we look for? Portal vein thrombosis. What type of hypertension? Splenomegaly, portal vein thrombosis, and splenomegaly. What do you call it as?
Left-sided hypertension.
What portal hypertension?
So left-sided portal.
Isolated portal hypertension.
Isolated splenic.
That is, in that case, you got to plan first splenectomy also.
Splenectomy also. Sir.
Yes.
Harsh, just one question to you. What is the role of endosono as far as the management issue is concerned? Endosono, management issue is concerned.
Okay, sir. So endosonography, sir, in cases of pancreatitis, which are responsible for gallstones, sir, we can see the distal CBD properly.
No. I'm straight away.
Just for the management.
Don't bring gallstone now, has been already discussed.
Yes, sir.
Endosono and the management. I'll give a clue to you. Endoscopic cystogastrostomy.
Yes, sir.
What is that things which are two important issues which you can get information by endosono? One is
the distance of the cyst from the stomach.
Yes. Second, should not be more than few millimeters, 2 or 3, I think. And another one is
It's the presence of
gastric varices.
gastric varices.
Because you may puncture the gastric varices. So you need
Yes,
to, that is one important information. Okay.
yes.
Yes.
How do you know it is communicating with the duct or not?
Sir, for that we'll have to do, if we go by imaging, we'll have to do an MRCP, sir. For that, we'll have better idea for communication with ducts.
Prefer ERCP or MRCP?
Sir, ERCP can be also be done because nowadays it is also being used as a therapeutic modality.
So you don't have a facility for MRCP, ERCP. What else? What you can do?
Sir, we can do we can aspirate the cystic fluid, sir, and we can send it for three things: mucin, CEA, and amylase. And according to that, we can classify it as pseudocyst, serous, mucinous, or intrapapillary mucinous.
When you say it is intrapapillary mucinous, APMN, what level?
So mucin will be positive, the CEA will be high, and the amylase will be high.
How much? CA will be high means what? Even 5 is normal. So it is high.
Sir, I don't remember the value.
So only when it is more than 400.
Okay, sir.
So you suspect that it's a possibility of malignancy. When the serum amylase is increased at least more than 3 times minimum, then you think there's a possibility it is a communicating with the duct. So even more than what TRCP and MRCP will tell you, your aspiration and doing the test will help you to know whether it is a communicating. So two need to be, one is non-communicating and there is no aneurysms around. Then these two are very important for you to assess. And as I said, endosonogram will tell you the distance and also to some extent thickness. Though nowadays we don't give much importance to the thickness, but the maturity can be identified by the endo ultrasound.
Okay.
So you have, because this patient is just 1 month duration, the pain is continuing. He is having acute pancreatitis. You said chronic or acute pancreatitis.
Yes, sir.
So what you are interested to do only management of pseudopancreatitis, or you are interested in the pancreatitis also?
So both the things, sir, because we'll have to counsel the patient to stop drinking alcohol first, so that the pancreatitis does not.
Recurrence of the pseudopancreatitis?
Sir,
it is very high.
Very high, sir. I don't know.
So what do you want to do for this patient?
Sir, since the history is of 1.5 months and the patient has complaints which are the patient is getting disturbed by his complaints of early satiety and loss of appetite. So in this case, we can go for an intervention.
What is your indication for intervention?
Sir, either if the patient is not symptomatic and less symptomatic and it is a first episode, and we can wait for intervention and see if the pseudocyst resolves spontaneously, because most of them resolve. But in cases where the patient has infected pseudocyst, the pressure symptoms are very severe. There is jaundice. There is
you mean to say it is infected, you will go for internal drainage?
Not an internal drainage. For intervention.
Intervention. Oh.
Yes.
So the old concept of the 6 centimeter, size, 6 weeks, 6 millimeter thickness is not mandatory.
Not
when
mandatory.
If the size is less, when the symptoms are persisting, that you can take up the case for. So what are the options you have?
Sir, we have endoscopic, laparoscopic, or open surgeries. Sir, and in endoscopic, we have endoscopic cystogastrostomy or endoscopic sphincterotomy with ERCP guided drainage of the cyst. We have laparoscopic cystogastrostomy or duodenostomy or cystojejunostomy, and open same cases.
So
Same these.
you have opened the stomach and you are seeing multiple vessels are there.
Yes, sir.
Varices are there, large vessels. What option you have? Or preoperatively, you find there is a lot of varices, lot of things, and what procedure you should do before doing a surgery?
Sir, we can do a shunt
Subject the
procedure
patient for
to-
either embolization, therapeutic embolization.
Okay. Therapeutic embolization or shunt procedure to decrease the portal hypertension first.
Shunt procedure is not done.
Okay. Yes.
Unless, as Sarah said, when you are thinking of a splenic vein thrombosis, you are also thinking of a splenectomy.
Yes, sir.
Routinely, do the embolization is done because many times it will go for the bleeding.
Okay, sir.
What is the principle of this anastomosis?
So, anastomosis, sir, principle. Firstly, when we do the anastomosis, we first take the posterior hemostatic suturing of the wall of cyst with the posterior wall of stomach. And once, because we have done this anastomosis, the drainage of the contents of the cyst continues through the stomach, through the alimentary canal. And with time, within 3 to 4 months, the cyst reduces in size and becomes a part of the wall of stomach.
So it will not go to the cyst, the food you are taking?
So we have to do the anastomosis on the most dependent part of stomach, so that the food does not go into the cyst.
When you have a dependent part, it can go to the cyst.
It will go into.
No. Why
Yes,
it is not going? Any reason why you think that it will not go to the cyst?
Sir, the peristalsis of the stomach itself will close the anastomosis while there is food in the stomach.
The pressure difference, the pressure in the intracystic pressure, which on the cyst wall, because it is closed, surrounded, the pressure inside the cyst will be more than the pressure inside the stomach.
Okay.
So it can go. What is Venturian effect?
Sir,
When the via naturalis is patterned, the side hole will heal.
yes, sir.
So when you have no obstruction in the distally and the natural peristaltic movement is there, the
Yes,
fluid will not go to the
other tracts.
What are the causes of spontaneous regression of the cyst? How it? What are the mechanisms? Various mechanisms. Spontaneous regression of pseudocyst occurs.
So the mechanism is due to its communication with the pancreatic duct. The pseudocyst can drain into the pancreatic duct and disappear. And,
Rupture. Okay, rupture of the cyst.
Okay. Rupture of the
fistula formation.
Fistula formation.
Internal fistula formation.
Yes, sir.
With the hollow viscous.
Yes.
Also possible.
Any indication for excision of the cyst?
So distal pancreatic cysts which are disrupting the duct. We can do a distal pancreatectomy for.
There is the current cyst in the distal pancreas. You can do the pancreatectomy, but otherwise you don't. Normally you don't.
We go for internal drainage.
So what are the indications for external drainage?
Sir, external drainage is not done generally, sir, because it might form a pancreatico-cutaneous fistula because of the enzyme, high enzyme.
There are certain definite. Suppose it is an infected pseudopancreatitis cyst. Will you do internal drainage?
No, sir. No.
So that's external drainage has its own indications.
Okay.
So the indications for external drainage.
Sir, infected cyst, then difficult anatomy, that
What will
is
you do
not
for
possible.
walled up necrosis?
Harsh, will you do it in a such moribund patient who is not fit enough for a say surgery, major surgery?
No, sir. Not in major. It is a major surgery, so we won't take the risk.
No. Listen to the question. Sir is asking external drainage. But that is
Okay.
a measure in your hand when your patient is not fit for surgery and it's a moribund patient with multiple comorbidities, right?
Yes, sir. Okay. Okay, sir. Okay.
The Kanavel sir has put some message. Kanavel sir?
Yes, sir. No, sir. Ramanand sir wanted to leave. That's why I put thank you, sir. He has left, I think, already. So he has messaged that he wanted to go. That's all. In fact, he wanted to stay only till 9 o'clock, sir. So he had some work, he said. I think all of them are traveling tomorrow for the exam, sir. I think
All surgeons are on the move tomorrow.
Sorry, sir.
All surgeons are on the move tomorrow.
I think
for the
37 centers across the country, which makes 150, 170 examiners are moving, sir, and plus the conveners have to set up things. Anyway, sir, please continue, sir. I think we'll finish this.
you can ask on the advances.
No, sir. Actually, sir, the point which you have raised, whether we can do internal drainage, have been debated at multiple sectors, sir. They claim many times it is sterile, but sir, moment it comes out and gets exposed to the aerodigestive tract with the presence of, even though bowel is claimed to be anaerobic, but lot of enzyme exposure and acid exposure, many bacteria dies within few hours, sir. Moment the gastric exposure and alkaline exposure, many bacteria dies. Maximum what they claim is if there is extensive necrosectomy, sir, even though they do endoscopic procedure, many times they don't bring outside, they drop in the stomach only because they have over tube and they pull out the necrosis 15 times, 20 times also. But definitely some spill happens into the gastric lumen, just passing to the small bowel. They maximum give couple of days loose stools. That is all they give. Otherwise, there is no real-time systemic risk to get into the sepsis, sir. Because pancreas systemic risk is more than getting into the luminal viscera to get exposed. That is one. Then, sir, as you know, the Atlantic classification has reclassified this. I hope this boy should have studied because they already done cystic internal drainage.
Yes.
Now, actually, sir, they claim if it is a drainable externally or internally, they give first interventional drainage a choice. Then comes the surgical thing. But surgery seems to be a one-stop option because patient becomes well for good. As you rightly pointed out, if there is a requirement for excision or doubt of excision, then primary surgery becomes the priority, sir. Actually, the debate is you should do an endoscopic ultrasound before handling the pancreatic cyst drainage or not. Otherwise, the next best is you do a CT. As long as we don't have heterogeneity in the wall or in the content, then you go for drainage options, sir. In spite of that, the global incidence is at least 7 to 8% of the cystic neoplasms are drained into the lumen after the advent of it, sir. So that is one risk, theoretical risk we have. More so, sir, if you are doing a laparoscopic cystogastroscopy, we can easily do a wall biopsy, sir. In LAMIS, like the lumen occluding opposing metallic stent, the endoscopist is requested to do a biopsy. But wall biopsy is a little challenge because, sir, they only pass a guide wire across from the stomach to the cystic collection. So the stent goes first, sir. It is a metal stent. So taking a wall biopsy is definitely challenging. But they claim they can do a JM anywhere and do a wall biopsy. But surgical biopsy is full thickness, sir, as everybody will know. All the surgeons here will agree to that. But I think these patients need to be followed up, and they claim even if there is a cystic neoplasm which is drained into it, follow-up scan, if it is shows, we can always go for a surgical removal without much added risks. That remains the current guidelines for the cystic neoplasms. So even doing accidental drainage into the system does not harm or does not give a bad outcome in this patient if you're going for a secondary excision of it. This is from my side. And now overall, the newer markers are coming up. So the mucin specific markers as a radiopharmaceutical are coming up. And then as well, we have the fibrin based PET scans are coming up. So the fibroblast levels and the plasma fibroblast ratios are helping out. I think those are all, we have another 3-4 years for us to make into regular use. So the student should be aware because these are all recent advances. The fibro scan is going to come up in a big way. So already it is coming. Now the most recent one is the US also has a fibro scan option. I don't think it is commercially available anywhere in India, but the fibroscan option has been added to the endoscopic ultrasound. So endoscopic ultrasound helps you to understand whether it is a uniform cyst or a cyst wall heterogeneity is there, then you go for a surgical option. And what is the most dreaded risk of cystogastrostomy or endoscopic Lamis placement, Dr. Harsh? One thing everybody is worried
could you repeat,
about.
sir?
What is the most troubled or feared complication of this type of drainage into the enteral or drainage with an endotherapy? So bleeding is the one should be aware, because many times there is severe autodigestion because of pancreatic activation, that is enzyme activated pancreatic enzymes in the cyst. These bleeds are, they go sort of, technically you can call as hemosuckers, but then more of pseudoaneurysm.
Yes,
many times, once you, actually it is a control thing. That is why these patients always should do a contrast enhanced CT before planning for it. If there is a spill of contrast into it, only surgery is the choice, or like in Chennai, Mumbai, you have interventional radiology, DMs have come in. So those people can embolize that and then you go for an intervention. So contrast CT, if contrast is freely flowing into the cyst, please be careful, because it is a controlled thing which is maintaining the bleeding to go slow or stop it. Moment you decompress in any form, surgical or interventional or endoscopy, bleeding becomes very difficult to control, because the feeding vessel access is very challenging in acute situation. So those are the conditions where you go for a interventional coil ablation. You do a repeat scan after 48 hours, ensure there is no contrast spill into the cavity, then you go for intervention. These are few additional points one should be aware whenever, because you don't have an immediate access. Moment you do an endotherapy, bleed starts coming. Surgery, you have all the options. You can ligate all the peripancreatic vessels. You have so many options. But in case of these collections, your anatomy is totally deranged. It's very difficult to control the bleeding. Can you tell what is the rank in the body for the pancreatic blood supply per minute per gram tissue?
Sir.
It's a difficult question, but I wish you people go and study for tonight, because it ranks almost at par with brain, liver, and pancreas are the most perfused, then to the kidney. These are the most perfused organs, and more so with inflammatory evidence, the circulation goes up 2.5 times the normal circulation. So it becomes very difficult to control the bleeding. Many fatalities have happened following this, even though they are very rare. Fatalities have happened, so you should be careful about these things.
So
even in surgery,
you have, without embolization, you are opening, you are seeing multiple vessels. What surgical option you have?
Sir, as long as it is not bleeding, we can just drain and come out, sir.
Or you can do the circumferential, that hemostatic stitch, somebody. So that,
sir, ideally, it is better if we do a stapled cystogastroscopy. That way is safer. You use that variable purple cartridge where you have variable height staple loads. That is safer. Sir, I still will be very skeptical to do a continuous stitches there, because you end up risking more every puncture you do in the wall, sir. So it is better you do the minimum possible and come out if you don't have bleeding. If you have bleeding, like how we pack for solid organ bleeds, you can pack the cyst with like laparostomy you can do. Pack the cyst with good amount of, like you have throat packs and other things, you pack and come. That is the ideal choice. Definitely to be done in highly specialized centers which have all the backup. Many times you don't have interventional radiologists available for you. So it is better these things are done in a specialized center. I think in your case, you have done a laparoscopic cystogastrectomy. Am I getting it right? Or open cystogastrectomy?
Laparoscopic.
Praveen sir is with us. No, has he joined now? Professor Praveen Suryavanshi?
Sir, I don't think he has right now.
Because he said he has some work. Anyway, I will speak to him tomorrow. Do you have any questions, Dr. Harsh?
Sir. Sir, exactly, sir, when should we go for a endoscopic drainage and a laparoscopic versus laparoscopic, sir? That is always.
Sir, actually, truly speaking, if yours is a very specialized center, the choice should be first endoscopic drainage.
Okay.
By surgeon or by gastroenterologist? No? Endoscopy then what you are doing, but who is doing is also important.
But the thing is, if you're doing an endotherapy, you should always have a surgical backup. That is more important. If you are having a trouble, then surgical colleagues have to step in. So if you are doing endotherapy, it is better you do under full anesthesia, because these procedures have to be done in a hybrid setup, theater, and then with all the facilities and infrastructure. That should be the right approach, with adequate backup of fresh frozen plasma, blood, and other things have to be having an adequate backup. Many times there will be always an element of subclinical sepsis syndrome. So these people will have minor derangement of clotting functions. Because this is close to the liver, there will be some amount of sepsis, systemic sepsis through the portal systemic communication. So one should be wary of it. These patients are little fragile. Just be cautious about it.
Yes, sir.
Okay. Any other questions? Faculty, other comments also. Saravanan sir, Amit sir,
What is the incidence of multiple pseudosis?
Saravanan sir, tell me.
We come on multiple pseudosis and incidence.
Sir, possible, sir. We have placed up till 6 tail catheters for multiple collections. Sir, many times
pseudosis incidence. Okay.
You mean to say multiple pseudosis? Am I getting it right, sir?
Question is to Harsh, not to you.
Yes, sir. Incidence and management.
Sir, almost 17% is the incidence, sir.
Okay. Thanks.
Selection of I think the case is very, very important, Harsh, while managing it, because lots of these things are confused, mistaken. Acute on chronic pseudocyst, acute inflammation is missed, then cystadenoma is missed. So a deserving, we'll put it in that order, in the sense very symptomatic pseudocyst, whatever you can call it as, a properly located with a good compression on the stomach. It has excellent results on a cystogastroscopy with almost a good cure, provided the basic disease, basic disease is also there, that precautions and all are taken. I have the experience of one recurrent pseudocyst with the cystogegenostomy. Some comments connect well, because it was a little far away, almost descending into the mesocolon there, quite a distance. This is the time before the days of endosone experts. We did a Roux-en-Y actually cystogegenostomy, and I have one bitter experience, very frankly, to tell that cystogastrostomy done with all the thing, but this is again before the days of endosono, turned out to be cystadenoma. So
okay.
In addition to so many other things, we get lots of chronic pancreatitis pseudocyst in our area. I think JLR also may be getting the tapioca related issues here. So we do get used to get a lot of cases of this chronic pancreatitis pseudocyst. Some ones got confused for also actual cystadenoma and got into trouble like that. I'm not very sure. One of the concepts probably Kanakville can clarify. The head of the pancreas, one region has been called as pacemaker of the speed. Pacemaker means the main, all this pain, whatever has been explained, is located in the head. That was probably the basis for the head covering surgery, correct? The initial part of the phrase, whatever they call it as for the, if it is related to chronic pancreatitis, with the, you do the head covering with the ductal opening and then probably LPJ. This is how it was done usually initially for a cyst located in that area. I think that's all about a few things, comments on this. Yes.
Sir, I think the Kerala surgeons, especially the Lakeshore Hospital, Dr. H. Ramesh, I think he has published more than 2,000 cases of chronic pancreatitis. So he always believes in excisional surgery than drainage surgery.
Yes.
So he resects almost head. Sometimes he, in fact, goes all through, like he clears off the head, body up till the neck, he clears off, and then only they do drainage. And that too, sir, they give a drainage like capsular drainage. It is not like your pistos typically where we open the lateral duct alone. He opens the entire head. He directly takes the nearby available small bowel or the stomach. It goes, the entire thing is drained, sir. He believes in it. And in fact, sir, he even in his big longer series, there is presence of malignancy in up till 4%, he claims, sir. 3.7 or 4%, if I could recall right. So he says of the 2000 number, 37 cases or 40 cases ended up to be a post-operative malignancy. Post-surgical pathology was reported as malignancy. That is the next important problem people are facing with chronic pancreatitis, sir. But one thing, sir, of late, what we have started doing is the pancreatic endotherapy has come up in a big way, sir. If there are multiple collections, before draining or operating, we do a pancreatic duct stenting, sir. So the communicating cyst nicely collapses. So what remains alone, we go for surgical things, sir. That is very helpful. Now ERCP fine stents are there, sir. Even 3 French, 4 French stents are there. They nicely put into the pancreatic duct. Many drainable cysts, they drain off. While doing it, they also do a balloon sphincteroplasty. So that way it decompresses the pancreatic ductal pressure, sir. And many communicating cysts collapses very well, sir. What remains alone, we operate.
Yeah, Dr. Kanagavel, I fully endorse your comments. At our center also, whenever we are doing such surgery, the coring of the head and the neck of part of the pancreas is actually has become a, you can say, a necessary and essential component of this surgery. Otherwise, patient doesn't get due pain relief in the post-operative period.
Okay.
Any other comments, sir? Harsh, do you have any other questions? Faculty, Saravanan sir, Amit sir, anybody? Can we call a close?
Yes,
Sir.
Thank you very much, Harsh. Give our respects and regards to Professor Suryavanshi, sir. Anyway, I think we are traveling to Aurangabad next month for your endoscopy with the Amasi program.
Yes, sir.
Thank you very much.
Sir.
Thank you, Saravanan sir. Amit sir, thank you very much.
Thank you, sir.
Shanai sir, Jailal sir.
Thank you. Good night.
Thank you very much, sir. Thank you. Kanna sir, thank you very much. Good night, sir.
Thank you. Good night.
Good night.
Karnakaran sir, good night. Subham, thank you very much for joining today.
Thank you so much, sir.